Well, hello, good evening. Welcome to the Institute of Healthcare Management and the latest in our fabulous Health Chat series. And this evening, I'm rather privileged. We are rather privileged because we're going to get all the insights, experience and expertise from the grand dame of public health, as far as I'm concerned, the fabulous Shirley Cramer CBE, in conversation with, of course, Roy Lilly. I'm going to hand over to Roy in a moment. All I will say is, if you'd like to ask questions at all for the end, do please use the Q&A feature at the bottom of your screen, and I'll facilitate that at about 5:30. For now, though, Roy, over to you.
John, thank you very much. Good evening, good afternoon, good morning, whenever you're watching this, wherever you're watching this, you're very welcome, and thank you for tuning in. You know, if this was like a real conference, by now, I would be on the podium and I would be saying, I'll be tapping the microphone and I'll be saying, right, settle down, please. And I'm just about to start and the door would open at the back and someone would come in late, wouldn't they? There's always someone who comes in late. And they do that thing, don't they? They look around and they see the only place to sit is right at the front. So what they do is they put their head down, look at the ground, and they shuffle in, and they think that because they're not looking at us, we're not looking at them. But of course, everybody does look at the person who comes in late. Now, the reason I'm saying this is that I don't think these Zoom conferences are any different to real conferences, because I think right now there will be people with their screens are saying, I can't make the sound work, or I can't get the picture up properly, or quick, I need to go and get a cup of tea or a glass of wine or whatever it is. So I'm giving you a few moments to settle your bum before we start. Shirley, good evening. How have you been? How's lockdown been for you?
Well, I've been very lucky, Roy, and good evening to you and to anybody out there listening. So it's been okay. You know, we've had a garden, the weather's been okay, frustration along with everybody else. I've been eating quite a lot and talking to people on the phone a lot and doing a lot of Zoom calls. So I expect that my experience is very similar to everybody else's.
Yeah, I've turned into a sort of a lockdown layabout, really. And I've been licensed by the government to sit on the sofa all day and just complain about things, which is, I found I'm really very good at that. I can do that. Right, I'm assuming everybody who's aboard is aboard and we're all settled down and we're all ready. John's given me a nod. It looks like we've got the G and go, so we'll go. So Shirley, I don't know, we're going to look back on this. You're, as John said, the grand dame of public health, just recently stood down as the chief executive of the Royal Society of Public Health. Has this been public health's finest hour?
No.
Discuss.
Discuss. I would say this has not been public health's finest hour. But actually, what it really strikes home to me is that politics trumps public health every single time. And you can have all the systems in the world, the best epidemiology, people on the ground, wonderful, and you can have all those things, but unless you have the politics, unless you have good decision making at the right time, then, well, I think we've all seen what has happened. And countries, many countries which have less money, less preparedness, less public health expertise, have actually done quite well during this epidemic because their politics worked, because they made decisions, they stuck to them, they didn't zigzag around, they were very clear about what they wanted, and they've seen less deaths than the UK. So I wonder what it's going to look like, the inquiry or the question marks around this. And I would say the big picture is that we need to look at how decisions are made and when they're made. And the politics behind this has been extraordinarily bad and difficult.
It is interesting, isn't it? Because this whole COVID event, if I can just sort of use the shorthand of event, we all know what it means. I mean, it's been a huge tragedy for people, but it has kind of redefined a new boundary, hasn't it, between politics and public health. And really that boundary has not existed before. Public health has got on and done what public health did. It did it in the NHS, and then it was shifted you know, shoved up the back passage of the town hall, and no one was very happy with that. But I would just wonder really whether public health was robust enough to be able to withstand the rigors of the political relationship.
So that's a brilliant question, because that is really the question that's going to need to be asked, because in other ways it was fit-ish. So if you look at other countries and their public health systems, they have also not had the investment. So Germany's public health system has not had the investment. We've had all of the years since 2013 or 2010 really of all the public health disinvestment in local authorities. So other countries have had the same, but we've still had a level of preparedness that's quite good. What we haven't had is political capital. And you need some political capital really to make things work better. One of the things that I've thought about quite often since is the siloed system. I know you've written about it quite a lot, Roy, but I think when we really needed our system to be effective, the silos and the cracks in the system, the gaps really showed through. People not talking to each other, the right hand not knowing what the left hand's doing. The one big area, massive problem, was not talking to local authorities right at the beginning. In February, talking to every single chief exec and council chief, public health teams. All of those people could have been deployed on testing and track and trace right at the beginning. None of that took place. So the system that we've created just didn't work because of the issues that we've seen on a month-by-month basis.
Yeah. I want to come back to that in a moment, because I mean that's the heart of it. But I just want to unpick some of this and what has happened. I mean, if we look at public health, I mean, I know there are people who work in public health who are really very pleased to see public health move back into what it calls its natural home, into local government. I mean, for all of my time in the NHS, it's been in the health service, and its natural home seems to me to have been in the health service. And I'm still not sure, I'm not convinced where its natural home is. I mean, maybe it should be an arm's length body. I don't know. I mean, like, you know, public health at the top is an arm's length body, but it seems to get a very sort of confused diffusion into the system, and I'm not quite sure who's responsible for what. I mean, Public Health England does Porton Down and pork sausages and everything in between. I mean, it's a huge straggling organisation. It may be too big, but I mean, if we look at the national role for a moment of Public Health England, it first of all, I mean, if we look at testing, it was responsible for getting testing up and running. Now, perhaps it's too early to ask this question, but I'll ask it anyway. I mean, was that asking too much, do you think, of public health?
I think it was a lot.
A national testing program.
I think what they did was kept it very close, narrow. So what they said was Public Health England testing. They didn't go far and wide like they did in other countries and said, who can do testing in your area? Who is capable of it? And is 70% good enough? No, it had to be the 100% the way PHE did it. And actually in other countries, you didn't need to do that. You could have widened it out and done testing that was 70% good enough in lots of different places. Yeah. So this narrowness was a problem.
Yeah. Just for people who are watching are not sort of quite au fait with what you mean by that. The Public Health England have a very rigorous set of rules and standards to license laboratories to undertake this kind of work, because they say it's got to be done right. And I remember Chris Whitty, the Chief Medical Officer, very early on saying a bad test is a dangerous test and it's no test and all of that. And Public Health England wanted to impose a rigorous set of standards, which were really quite hard, I think, for people to fulfill. A lot of the private laboratories found it difficult. Do you think that they were overprotective of those standards?
It's my view that in the sort of wash up around this, that will have proved to be the case. Because if you look at what's happened around Europe, by adhering to those really tight standards, it meant that we had very few tests, very few places that were able to do it. And what you needed was it to be much wider, broader. I think when you're in a crisis, time really matters. You know, time isn't on your side particularly. So to get anything 100% right, you actually need quite a lot of time. No, get out there, do it. And I think somebody in the World Health Organization is very clear about that.
Yes,
that just get out and do it.
Yeah, it was the president of the World Health Organization, the guy with a spectacularly long name.
Tedros, from Ethiopia.
If you had it in Scrabble, you know, you'd have a triple word score and you'd break all the records. Wonderful name. But he said, didn't he, test, test, test. And we stopped test, test, test.
We did.
And it's emerging now that we stopped, not really because of the scientific thing in me that said, oh, there's no need to do this. We stopped because we couldn't do it. We didn't have the resources to test generally in the population and to be able to test in the hospitals. And it struck me as surprising because most hospitals have got a path lab. They could do their own tests. I mean, why didn't they? Do we know?
Well, we don't know. I think one of the other issues that's going to come up is that the lack of transparency. I mean, one thing I'd say about particularly the New Zealand system is a good example of how open their Jacinda Ardern was about the issues they had, the problems, so this is what we're going to try and do, and this is what how we're going to do it. This was a very open conversation with the public, with everybody involved. And of course, there was a lot of trust in that. When you don't have that transparency, nobody's quite sure what's happening, who's involved, who made that decision. And I think this is a difficulty. You begin to sort of question, well, why are there only 25,000 tests when we clearly could be doing a lot more?
Exactly.
You know, these are questions then that become really important. And if we've thrown it open and been less, I think, narrow, less centralized, I think the centralization of what's happened and the save the NHS, and I totally understand that. But actually, in most people's mind, save the NHS came before saving lives, and it did on the podium. And we were so worried about those scenes from Italy, you know, with very ill people not being in the ICU, that became every piece of decision-making, and effort seemed to go into that. And the stuff on the ground that really you could hopefully have done at the same time as you could save the NHS, but also get these systems up and running, if we had talked to local authorities and teams earlier and got those going at the same time in parallel with saving the NHS.
Yeah. Well, now, I mean, this whole transparency thing is interesting, isn't it? Because when this started, I remember the Prime Minister saying, we're going to follow the science. And I think, you know, everybody thought, oh, science, you know, that's the kind of thing that put men on the moon and Einstein, and it's all very accurate and formula, and yeah, we should follow the science. But it's only now, I think, that I mean, I wrote about this today in my e-letter, where I had a good look at SAGE, and it's a kind of a loose collection of the willing and the able, and how they get selected to go onto their SAGE committees, I don't know. It's not transparent. Some of the people who are on the committees decline to have their names published. Well, really? I mean, why? You're a public servant, you know, why would you not want to say, yeah, I'm on SAGE? And why do we give them the option anyway? What are they trying to hide? And then there's this very unhappy relationship between the fact that there isn't really science. This is an opinion based on some numbers. And so people make a broad choice of options, I think, present them to politicians, and the politicians then kind of make a decision and say, we followed the science. Actually, that's not right, is it? It's not like that. It's a misrepresentation of what actually has happened.
It's very interesting you mentioned SAGE. I think the lack of transparency around that from the beginning has again been problematic. Also, there are a lot of academics, which is a good thing, a lot of epidemiology, but modeling can be done in different ways. And so people would use different ways of doing the modeling around the numbers. And And I think that's actually quite difficult for politicians too. What they didn't have on that committee, as far as I could tell, was people on the ground, people who were in locations and regions, or people who were actually in communities. So, as I said, chief execs of local authorities, directors of public health, these are the people you need in the room because they're practitioners. They know of what they speak. We do track and trace all the time in terms of, you know, STDs and, you know, environmental health officers do this all the time in tracking food. So, you know, there's expertise out there that wasn't being used, and at senior levels should have been represented.
Let me just put the counter argument to that. I mean, certainly there is a residual set of skills in public health now in local government. And yes, they did HIV, and yes, they do, you know, if you report food poisoning from a restaurant, they do all that. But actually, these are pretty low numbers, aren't they? You know, sexual transmission, the number of partners, well, I mean, that's fairly easy to identify. People in a restaurant a certain night that have been ill, that's fairly easy to identify. But when you get something like this, where we don't really know what the transmission rates are, I mean, the R number is, you know, an average and a fiction as far as I can see. It's all we've got, but it's still a, you know, flip a coin. We don't, a lot of people are asymptomatic, spreading the stuff. I mean, do you think that the public health infrastructure as it is, and as we found it at the beginning of the outbreak, do you think they were robust enough to take this on?
Well, they could have been. They could have been, Roy. So if you had said, okay, it is your responsibility. There's a very interesting notion that I picked up in my 7 years at RSPH about England and about the way we do things, and that is permission. And people seem to be, I worked in New York and Washington, DC, and New Yorkers tend not to be, you know, fight for permission. They just tend to do it anyway. It's a very American way of doing things. And here, I think people are waiting for permission to get on and do things. And where you have a more federated structure, like Germany, like other countries, Vietnam, they were getting on and doing things because they've got the framework, and they can muster other people in the public sector. So it isn't just your public health team. You've heard me talk often about the wider workforce for the public's health. You could invite all those other people in the public sector to be part of that team. So you could quickly amass the people who are already paid for and working for you and put them in a certain direction. This is the challenge you have, and they know their communities. That's the advantage of the on-the-ground people. And they've got the languages. So centrally, if you're trying to do track and trace, you know, what do you need people tracing and tracking in the call center? What, in 40 different languages? I mean, there are clear problems when you diffuse it to the end of a telephone line with people who've had half a day's training. So you might have a mixture of both, but you can never get away from the fact that on the ground working and letting people get on with it is a very sensible way in a pandemic of allowing things to happen.
Do you think that well, let me put it the other way around. Why do you think we didn't ask the people whose job it was to do the job? Why wouldn't you? I mean, if you were sitting in Whitehall, you think, blimey, we've got to track and trace. Okay, who does that? Local government, public health. Get them on the phone, get them doing it. Why didn't we do that?
Do you know, that's the question I would love to ask. So here's an example. So I've got friends in the Australian government, and I talk to them in Canberra. And, you know, I'm not a big fan of the Scott Morrison, the right-wing government in Australia, but what he did was, the first thing he did was he got on the phone to every premier across Australia, put them together in a big group, developed the strategy, and off they went and did it. We never did, as far as I can tell, and talking to public health directors and others, nobody ever got those groups together and said, okay, what can you do? When can you do it? How quickly can we do it? showing trust, showing that you, giving them the authority, the responsibility, and as you might say, Roy, bunging them some money, and it wouldn't have needed that much to get those systems up and running properly. And that just didn't happen. A lack of communication, a lack of bringing everybody in the picture that could have been helpful. And I don't know if that's a lack of trust or, you know, the relationship, it seems to me, is it's very odd, this relationship between the NHS and local government. In some areas it works absolutely brilliantly, and in other areas it works less well. But central government and local government, seems to me that there's a big gap here somewhere that I honestly don't know who would have that responsibility.
Maybe it's the attitude of central government, who just say central government can do this so much better. We don't trust local government. You know, they've had emasculated budgets. We've had a lot of failures in care homes. You know, maybe the central government just said there's nobody there good enough to do this, or whatever. I don't know. But I want to come back to this business of the relationship between science and politics, because I think this has put a lot of pressure on public health in the name of public health. I mean, actually, the SAGE committee, although it's sort of under the umbrella of public health, it's developed a whole life of its own, isn't it? I mean, if you'd have asked last year what is SAGE, then, you know, 10 people on a bus queue said, "I know it's sage and onion, and you stuff it in your chicken." You know, people wouldn't know. Now we all know what SAGE is. We're all epidemiologists. I mean, it's a bit like when, do you remember when David Beckham at the foot of that World Cup broke his metatarsal? And overnight, we all knew where a metatarsal was, and we were all experts on how to get it fixed. We're all epidemiologists now. We all understand the R number is valueless. We all understand that SAGE is a group of shady people who flip a coin, you know, do the best they can to give evidence. I mean, none of these structures, it strikes me, were in any way prepared for what has happened to us. I mean, we've just been kind of sideswiped by the impact of it and what it's done to our people, our families, our businesses, and the economy. We just, whoever was there, we just wouldn't have coped with it any better.
I think well, I can say it. I mean, I think we've had really poor political leadership on this.
Do you think it mattered that in the middle of it, Or Johnson was unwell and there was no obvious successor? I mean, we had Dominic Raab, who looked as though he'd been run over by a bus, didn't he? Rabbit caught in the spotlight. He was shell-shocked, I think, to find himself where he was. Do you think that gap was important?
That was a big gap, and you know, Matt Hancock has really worked hard. I mean, he's certainly, I can only say he's within the difficulties he's had. I presume, you know, I know he's tried his best, but you know, this shilly-shallying we had a lot. We might do this, we might do that. The lack of leadership around that, and if you look at other, and it is useful to look at other countries that have been successful.
Yes, well, let's look at some other countries. I mean, if you just look back in history, I mean, the Iraq War, for example, we were all sideswiped by the Iraq War. You know, made some terrible decisions. A lot of people died, and it's still not over yet. Then we had the world banking crisis. A lot of people saw it coming. A lot of people said we got to be prepared for the world banking crisis. Nobody was prepared. Guess what? It sideswiped us again, destroyed businesses, lives, ambitions. Yeah, and now we've had the COVID thing, and it's not like Bill Gates didn't tell us it was coming. It's not like Obama didn't tell us it was coming.
Yeah.
It's not like, you know, quite a lot of famous epidemiologists didn't say you've got to get ready for a pandemic. We didn't do that. Who did? I mean, Germany looks like they've come through it better. However, I read a piece at the weekend that said they've only reported 1 in 10 deaths or something, because the way they report deaths is different to us, and it's not quite as transparent. I mean, do you think Germany's actually dealt with this better?
I do, actually. And I think they've done better because they've had a lot of cases, but they've had a lot less deaths. So a couple of things on Germany. They have huge capacity in hospitals. They have loads. They have funded, double the funding. I think I read since about 2003, they've doubled the funding in hospitals in Germany. It's very standardized. They don't have an NHS, but they have got a very standardized system. in the hospitals. So they had the capacity, though they got retired doctors back and all that. They have a prime minister who actually, or a premier, so Angela Merkel is a scientist, the person that advises her. She's got quite a lot of scientists around her, and I think that helped in the communications. And she also was visible every night. It was the same person. If you look at comms, it's very important to have the same person talking. I mean, we've had a plethora of, you know, business and this and that person, minister talking about it. So we've had the nightly briefings, but it really would have been much more important perhaps to have slightly less, but have much more of the feeling of leadership and trust and that conversation, which never got to be potentially built up. And, you know, would it have been better if Boris Johnson wasn't sick? I'm sure it would have been, but
we are where we are. Yeah. I think it's interesting what you've said about the people who delivered the messages, because I spotted that quite early on. I mean, I'm a sort of political watcher. It's what I do, and you know, I'm a kind of nerd when it comes to all this stuff. But we had people in the early days standing up giving 5 o'clock messages. I had no idea who they were. I didn't have a clue who they were. I mean, that's much to my shame as much as anything else. But it does say something about messaging. I mean, what we know is you've got to get a person who has a manner that can be trusted. Generally, the best spokespeople are women rather than men, because women score more highly in public trust, and the messages have to be consistent. But what they did was they had a minister from every department that had a new announcement. So it was more about pleasing the department, I think, than it was about reassuring the public. I think it was a complete disaster how they did that. I really do. What about France? What do we know about France? Because they're doing unlockdown, if whatever the word is for unlockdown, lockouts, lock up. And they're doing it by arrondissement, aren't they, in Paris? Each little
yes.
Is
and
big.
So it's very interesting there, because there are some areas of France that were hardly, that they really weren't affected. So there's parts of the south with nothing, and then they had other areas that were very badly affected. So I think in the beginning we saw, you know, almost the Italian, that, you know, the thing that rising death rate, and then they had a very, very strong lockdown. I mean, much stronger than ours in terms of, you know, you needed a bit of paper to walk out the door. But they then got the R down quite low, quicker than we have been able to do. And now, you know, restaurants are open in Paris, they've opened coffee shops, stores are open. So even in the worst areas, they've now been able to open. And they did do a lot more track and trace locally, because they're their local systems.
Well,
their local systems came in. Yeah. I mean, they didn't do brilliantly, but they've done, you know, reasonably well. And I think certainly Macron has been very visible, and he's taken all the hits for things that have gone wrong, and has been very much, you know, it's been very clear who's leading it.
Yeah, I've been reading the English language version of some of their newspapers. It's quite interesting. You're quite right, taking it on the chin. Italy's interesting, isn't it? Because they had the Lombardy region, which was really hit very badly. But actually the rest of Italy have fared much better, haven't they? I mean, I thought it would just rip through the whole of Italy from the top to the toe of the boot, but it's not happened.
No, they were right. The south is, and they had, you know, they were really very, their lockdown really worked for the south. I'll tell you one thing that I think I wish could happen, and I wish that politicians would say that they're sorry for mistakes they made, because I think the public would understand that. But I think this general attitude of our apparent success, or some of these other language, is very bad at this point. I think they really should say mistakes were made, we're sorry, we wish we'd locked them. You know, people understand people making mistakes.
I think couching it in wartime terms as well wasn't helpful.
No.
You know, we are going to fight, we're going to win, it's a battle. Actually, it's not. If they'd have said, if we do this together, we'll come through it. But
yeah,
you know, trying to make it a battle, and but that's very much what the Prime Minister is, isn't he? He sees himself in a sort of Churchillian mould and wants a battle to fight, and it turned out to be a much bigger battle for him personally than he thought. John, I'm conscious of the time. You've got a question for us? Let's see what people have been saying.
Thanks, Roy. Yes. Well, first of all, congratulations both. Very, very interesting conversation. Lots of people enjoying it. Jim says Ceredigion local authority in Wales appears to have got things right with a homemade track and trace system. Could local authorities across the UK have done more rather than wait for central government to take the lead?
Yes, and if I could just add to that, I just want to say the word Ceredigion. It's such a wonderful way. I've got to say Ceredigion. There's another bunch of GPs, I think, in North London who were doing their own track and tracing as well. I read about them.
Yeah.
They didn't get too far with it in the end because they ran out of resource. But there have been people having a go at it. Come on, Shirley, let me hear you say Ceredigion.
Oh, I can say Ceredigion. Probably not as well as you, but I couldn't. I think that's a fabulous example of what I said about not needing to be the 100%, just getting on and doing stuff. And to have done that locally and been so successful really shows what we could have done if people had just got on with it and not waited for central government to give that permission I was talking about. And I'm quite surprised in a way that more areas didn't do that, because that's going to be the shining example of we can just get on with it because we know what needs to be done. And they should be really proud, actually.
I just don't know what Dido Harding actually is going to do really to kind of change gear on this, because without improvements to testing, there's not a lot she can do. I mean, she can really only move as fast as the fastest test. And we're still not able to turn around all the tests in 24 hours. I don't know why. I read this morning there's a shortage now of some of the reagents. We've gone back to where we started because we started, we didn't have enough reagents. Again, we don't have enough reagents. Now we're doing more. I don't know. Who knows? I have no idea. You got anything else, John?
Yes. Shane says, hello, Shane, by the way. Good evening. Is there something that we should do right now to prevent more sickness and potential fatality in relation to Monday, 15th of June, opening of shops and services? In other words, I think what Shane's trying to say is, in that we know that's coming and that has the potential to potentially catalyse a second wave, what lessons have we already learned that we could be doing now to ameliorate that?
Gosh, that's a really good question, Shane. I think we haven't talked enough about washing hands again, because guess what? That is still the most important thing to do for transmission of infection. So I think the face masks are useful, and it makes people feel a bit safer. So, I mean, psychologically, I think face masks, if you're inside, think the hand gel, washing your hands all the time. I really fear for the businesses, because it's very difficult. And we also must be slightly braver as well in our attitudes, I think, because, you know, at some point we don't want to be scared to death to go out to the shop. So I think he's right to say, what can we do? So have those scarves. I've got a ski thing I wear that you can just put up here, and they're really handy. So if anybody's got a little ski thing or a walker's, I don't know what you call them, but anyway, they're very handy for the face mask.
But the World Health Organization is telling us that only medical quality masks are any good, aren't they? I'm here to ask the questions, not answer the question, but I'm going to say what I think is, if we had more localized R numbers, we could be much cleverer about what we do, because there's no doubt about it. I mean, I'm speaking to you from London, in the borough that's had most deaths of anywhere in the United Kingdom, in the London Borough of Newham. And I tell you what, I mean, I'm not going to go out here until Christmas. And even then, I'm not sure I'm going to go out. But there will be other places, back in Surrey, where I live, the Frimley Park Hospital has never been full, I'm told. So I think if only we could persuade the politicians to do a localized R number.
And this is back to the track and trace and testing, Roy. This is where the localized stuff is really important, because then you could say, well, you know, this is a safe area. If we go to our local shops here, we're going to be fine. Just wash your hands, wear a mask, and the end of it. You wouldn't be worried. And that's part of the conversation that needs to happen with government, that we need to understand what's happening in our own neighborhoods. There was one point I understand that they weren't sharing data with local government. And you know, that's really unforgivable in my book.
Now, John, I can see the list of questions here, and I know the next one is from someone who's an old friend. We've interviewed him. He gave us a tremendous health chat. He's a celebrity in the health sector. I'll let you tell everybody who he is.
Well, we've got the fabulous Ali Parser on this evening.
Good evening, Ali.
Very privileged to have Ali along.
If I'd have known Ali Parser was watching, I'd have worn a tie. I'm sorry, Ali.
So I'm going to try to merge some of Ali's stuff with others, but there's a lot of talk about should there have been early international travel restriction, and should that perhaps now be a feature of our activity going forward? Should we ramp it up even further?
Yeah, and he's done a second one, isn't he, about antibody testing? I'll let you read that out in a minute. Well, I mean, okay, should we have closed down earlier, and should we still be closed down?
So should we have closed down earlier? I think if we, what I also didn't understand in March was why we didn't close down travel into the UK, because we are an island, and that would have made particular sense to do that from probably the second week in March. And then the fact that we went into lockdown on March the 23rd, and we still didn't close the airports for reasons that obviously other countries didn't think the science that we thought behind it. But it just makes perfect sense that if you're trying to support a lockdown, that you don't have people traveling in the country. I mean, I sit with people now think, here we are in June the 8th. How are they going to police the lockdown they have in the quarantine now? You know, the police can't do it. Public Health England can't do it. It should have been when we were locked down in March. And that's the crazy situation we're in.
And surely it's the only policy that's actually been challenged in the High Court. It does seem bonkers to me, but again, it comes back to the public health and the scientists. We were told that the scientists said there is no point in having Fortress Britain because the infection's already here. So it doesn't matter that 15,000 people were arriving at our airports every day.
Yeah.
I think that's bonkers. I mean, that's the kind of thing, for me, that gives science a bad name.
I really don't understand that either, I must say, because people I know who did come in during that time could not believe they weren't being talked to at the airport, that their temperature wasn't being taken, that they weren't, all the things that were happening in airports across the world were not happening here. And this exceptionalism that's been talked about in opinion, you know, columns and everything, this vision that we are different somehow. Yeah. We're different and bad. And in fact, if Ali's listening, this is really interesting because the app, in talking to the Australian government, they decided to go down the Google Apple app route because it was working in other countries. They saw it was working in Singapore and they got it working in Australia in 3 weeks. And then we decided to create a new app and not use that and test it on the Isle of Wight. And that again, I didn't understand because, you know, this is a global issue and there should be presumably some global solutions and we should be learning from other countries. And that I really didn't understand either.
No, I didn't either. If I may, John, Ali's asking us about the cost-benefit point of view of antibody testing. And the only reason I just wanted to step in, because you may not be aware of it, but there's a headline in the Daily Mail today saying that we wasted £3.5 million on antibody tests that we thought didn't work, but now apparently we know definitely they won't work. So whatever. Anyway, what's £3.5 million when we've been spending billions? But I mean, antibody testing, you know, right up your street, really, Shirley. That's the public health thing, isn't it? Do you think we should be doing that? Because
if we had one that worked, it would be useful.
Well, at the moment, if the way it's working at the moment, if somebody's at work and they are told that they sat next to somebody on a bus who identified them and said, you are you're within my ambit of people, they have to self-isolate. It's going to decimate hospital rotas. We're going to end up with everybody sitting at home.
Well, again, it's another thing that didn't make any sense in how that was done. And why aren't we learning from other places? We need to understand actually whether if you have the antibodies, how long they last. There's so many things we obviously don't know about the coronavirus and COVID-19 that we do need, but we have to do so here's my principle. It's health harms. Do the least harm that you can in this. So harm reduction, and harm reduction would be doing these things and doing them better. And somehow
it was like masks, wasn't it? It was like masks, the precautionary principle. We're not sure.
Let's use the precautionary principle.
So I think Ali's right. I think that to have the antibody testing to try and get people back to work, it makes a lot of
sense.
John, you got another question?
Yeah, I've got a really interesting one from Karen. Karen, thank you for putting this in, but she comes up with a super suggestion. She says, could we get these local R numbers simply by asking the population? In Redbridge, the local BAME group has asked for them and got them. Interestingly, high levels are only linked to deprivation, but also possible link to transport hubs. Is that a route? Again, localism at its best.
It all comes back to Shirley's concept of localism versus what is actually happening, which is nationalism. Not nationalism, but you know what I mean, nationalism.
I absolutely love that question because, one of the things we did at RSPH in everything we did, and I know we haven't talked much about what I did in that role, but it was always ask the public. We always talked to the public about their views, found out what they thought, checked our recommendations, did all sorts of focus groups. This is the perfect thing, is that the people in community ask that question, tell us what's happening in our community, and we can help form that response that makes sense to us, because it is in our best interest to keep our families and our granny and everybody safe and healthy, and our children. So I think that's terrific, and I think there should be more probing and asking those questions. Asking PHE must have some data, and asking if local public health teams.
Yeah, John, you got another one?
Yeah, we have another person living in Wales, very pleased with the Ceredigion approach. And we've got Elaine saying that she's in Ceredigion, she's very happy to be there, but people are scared of the end of lockdown and the return of holidaymakers. What are our thoughts about the Wales approach to lockdown, where no one can travel more than 5 miles?
What are the chances of having 2 people from Ceredigion in one?
It just shows the Welsh are taking over. I'm here as well, remember?
Yes, in Calbridge, yes. Right.
Well, it's a really, if you think about the hub and spoke model, or, we can have 3 friends we're all hanging out with, and that's the community. So if you know your community is safe, and there's no, as far as you know, no coronaviruses, you've had no cases for a month, you could be within and be totally free in your 5-mile radius. So in some cases that really makes sense, because you're not allowing those outliers or super spreaders or people to go to a barbecue 20 miles away and infect another 20 people. So it does actually make sense, but you do need to know the numbers. I think that, again, the Lynn approach with the Ceredigion approach, which says, let's ask that question and then let's figure out for our area what makes sense.
Yeah, I think it's right. I mean, people going back to their favourite holiday places, and there were some wonderful places to go on holiday in Wales. If I lived there, that would worry me. And look what happened in Weston. I mean, we suddenly had this spike, didn't we, just recently in Weston-super-Mare? And, wasn't it a fortnight after we did the VE Day celebrations? I'm not an epidemiologist, but isn't there a connection there that no one seems to want to talk about? Because it's all too difficult. Right. What else you got, John?
That's about it, actually. It's people have really enjoyed it. It has some really nice comments from people saying how fabulous that they think that it is to hear Shirley speaking in this newly released manner, really, now that
well, listen, we've got a couple of minutes left, John. Let's just talk to Shirley. I mean, I'm not going to ask you what you're going to do now because I'm not sure you know. But when you look back at your time at Public Health England, you look back on it fondly, I know. What do you think you achieved whilst you were there? What did you enjoy most?
So, RSPH, not Public Health England.
I'm sorry.
Right. So so I'm proud of you, had a great team there. And I think some of the things that we did around looking at emerging public health issues, and also, so things like social media and mental health, we championed that. Gambling in young people, we championed a lot of things around that. We looked at things through a slightly different lens, and we included the public in everything, and we made lots of recommendations. All our reports were full of recommendations that the public liked, so that when we talked to ministers, we could say, this is what the public think, not just me, and not just our science, and not just the work, the research, but this is what the public thinks.
You had a terrific,
so much more powerful in my way of thinking. So I think this reduction, thinking about the precautionary principle and trying to get ahead of the problem. So often, we let things go and then we say we've got a problem, but with social media, you really can get ahead of things and say, let's put that legislation in place. Let's do some things that can really can help. And I think online gambling is another area that we've been looking at. So I think I'm proudest of those things, plus the National Health and Wellbeing Awards, actually celebrating wonderful work that local organisations are doing around the UK, really brilliant work from voluntary sector, some local authorities, and having them have their, red carpet moment with the public health minister and celebrities. I thought that's what public health needed to have, to say that we're proud of that kind of work. Yeah.
You're a real fan of localism, aren't you? Do you think,
I am really.
I'm wondering really if this hugely central approach that the government has just trampled all over any hopes that we'll have of getting localism back. Do you think?
Well, I think maybe I'd like to sort of put that on its head a bit and say we've seen now that centralization hasn't worked. It really hasn't worked. We have, the worst death rate in Europe, and there's a reason for that. And that's partly because we tried to control it with a small group of people and politicians centrally, instead of, you can do lots of good things centrally, but then letting 1,000 flowers bloom with letting people get out there and do things in the same way that they did in other countries. And I think we'd have survived better and done better. I think people need to be writing about that now, need to be thinking about that, because we need to have those systems in place. And actually the local mayors, the local politicians needed to have a lot more say in this process.
Yes, I think Andy Burnham's done well, hasn't he, really, in trying to get his message. I don't know, I'm not sure what there was for him to achieve, but he's certainly done well the messaging. So, I mean, final question. John's given me the evil eye now. It looks like we've got to stop. But thankfully you can't see him, but I can. Are you optimistic for the future of public health?
I'm a born optimist. It's just you either come out that way or you don't. So what I'd say is I think it'll get a lot more attention. I think I think it'll be reconfigured differently. I'm not with you. I think that public health does belong in local authorities, because I think that's where the social determinants of health, that's where we've seen with the BAME review and all of those things that actually health is not the absence of illness. Health is about our health and well-being and happiness and all of those things. And that's a lot to do with education, housing, all of those other things, which I think we can do a lot with in local authorities. So I would say I think we'll just have to get over this and learn the lessons and really learn them well.
Yeah. Shirley, it's been, I don't know where the hour's gone to. It's always 45 minutes, that's all I've got. And I've over just looking at the time now, I've lost my performance bonus, Shirley, because I've busted the 45 minutes. So John will have to furlough me. But it's been fascinating to talk to you, Shirley. You deserve a break. You've done a terrific job, I think, whilst you were at the Royal Society. And I hope that we'll see you again, and you'll come and talk to us again, perhaps when COVID's a bit further down the line and we can have another reflective conversation. But thank you enormously. And we wish you a safe passage through COVID, and then whatever it is you plan to celebrate your far too early retirement, I think, but your retirement, perhaps you can get off and do it, because I don't suppose you expected to celebrate the end of your years there in lockdown.
I really didn't, Roy. And I'm doing a bit of non-exec work, a little bit still on the commission of the Food Farming Countryside Commission. I'm on the Alzheimer's Research UK board. I'm chairing the rare dementia support groups at UCL. And I'm the chairman of a think tank called British Future. So I'm doing a bit more with them at the moment, and that's really interesting.
Well, there's a lot we'll talk to you about at some time in the future. So bless you. Thank you so much.
Well, thank you for having me, and thanks to everybody who's been listening.
We've had a great time. Let me hand back to the boss, who's going to tell us, I think, what's next.
Thank you, Roy, and thank you, Shirley. Once again, Shirley, you won't know this because we've kept it secret, but on account of the fearlessness that I think has marked your time as CEO of the Royal Society of Public Health, your willingness to speak truth unto power, always. You've always represented the people and their opinions properly to politicians, I think, and we admire you greatly for that. And as a result of that, the IHM would like to award you a companionship of the IHM, effective immediately, and we'll be sending you a rather smart certificate for you to attach to your wall in the near future. But I just want to say on behalf of all the IHM members, many of whom were very relieved when the RSPH under your tutelage took on the IHM at one of its lowest ebbs and really rescued it from oblivion. So we all owe you a huge debt of thanks. I know everybody this evening has really thoroughly enjoyed listening to you and the sense that you've spoken. We've got some lovely comments. So thank you so much from the bottom of our hearts, from all of the IHM members and supporters, because I don't think we'd all be here today without you. So thank you for that. Final thing, if I may, we've got more fabulous online content to come, everybody. And if you don't know about it, well, join the IHM. We've got a fantastic free offer on until the end of July. You can join the IHM for free until the end of July, and then you'll just have to see whether we've provided you with value or not. In the meantime, thank you all once again for joining us. It's been my privilege and pleasure to be able to host Shirley Cramer CBE this evening. I know we will continue to see a lot of her. Thank you, everybody. Good night.
Bye. Thanks.